Kelbarczyk, Assistant Director of the Johns Hopkins Center for Global Health, and I'll be moderating today's session on NCD management in low resource settings during the COVID-19 pandemic. Today we have two speakers with us, and I'm very excited to introduce them. Dr. Hennis I've known for a few years now, so I'm excited to get to work with you in a bit of a different setting. He's the Director of Non-Communicable Diseases and Mental Health at the Pan American Health Organization and has a long history and vast experience while working with NCDs, working with low resource countries and government, so he's really an expert in the field. Joined today with Dr. Hennis is Silvana Luciani. She's the Unit Chief for NCDs, Violence and Injury Prevention, and is part of Dr. Hennis's team at PAHO. They both work closely with ministries of health to improve their public health programs, and as I said earlier, they'll be talking to us today about NCD management during COVID-19, which is something that certainly was not on anybody's radar at the start of the pandemic and is now becoming increasingly important as we continue through lockdown and are just having very many different implications. So before I turn it over to our speakers, just a reminder, use the chat function to introduce yourself, use the Q&A function to ask questions, and we'll try to collate and flag all of the questions for our speakers at the end for our Q&A session. So with that, over to you, Dr. Hennis.
Yes, good morning, colleagues, and a pleasure to be here again. Good morning, those who are participating. It's always a pleasure to work with the Johns Hopkins team and the network linked to Johns Hopkins. It's a pleasure to be here this morning with my colleague, Silvana Luciani. And our brief this morning is to speak about the issue of NCD management in low resource settings during the pandemic. Now, as we know, 6 months ago, we had no idea we'd be sitting here this morning talking about this topic. And in fact, the usual role that we have played with NCDs is to speak about the impact and the burden of NCDs in America. So I'll begin by introducing the context. Now, there are about 6.9 million deaths in the Americas annually, of which about 81% or 5.5 million are due to non-communicable diseases. Also, particular note is that about 39% of these NCD deaths occur prematurely. That's between ages of 30 to 70 years, when individuals are in their most productive phase of the life course, where they're contributing economically to their communities and to the nations. I said before, 81% of deaths due to non-communicable diseases, and by and large, the biggest cause is mortality from cardiovascular diseases, heart attack and strokes, etc. This is followed by deaths from cancers, which affect about 1.2 million people in the region of the Americas, followed by respiratory disorders like chronic respiratory disease and chronic asthma, as well as by diabetes that accounts for 5% of overall NCD-related mortality. Good, so we can go to the next slide. Now, we know that non-communicable diseases create a tsunami which impacts the health systems in the region of the Americas. And really, the underpinnings of this is that health systems were developed and structured to tackle maternal and child health illnesses and situations and conditions, as well as acute infectious diseases, whereby the contact was curative and the illness responded to treatment and interventions from the health system. So with that infrastructure for how the health systems work in much of the region, the low and middle income countries of Latin America and the Caribbean, what we now find is that the systems are unable to cope with this tremendous burden of non-communicable diseases. They're fragmented. There's lack of coordination between the public and the private health sectors, and the mixed subsystems in between. So therefore, there's poor communication. Quite often, the main hospitals are public hospitals, whereas people might receive care in the private sector. So there are problems of referral, problems of communication, etc. There's segmentation services between income tiers. And what this means is that those who have higher level of resource are able to access a different quality of services, whereas those with very little have very minimal or very basic resources. So there's disparity in terms of provision of care and access to services. There's limited stewardship of the health sector. So in other words, there's very little governance of the private sector, whereas there's far more oversight in terms of the public health sector or the social security health sector. Hospitals tend to form the basis of how health systems work. So quite often there's an issue of investments at the hospital level, whereas in fact, the bulwark or the core of a health system should really be at the primary healthcare level. So investing heavily in hospitals rather than in primary healthcare, prevention, and services at the primary healthcare within the communities tends to result in losses of efficiency as well as quality of services. A critical element of services is the need to invest and to progressively invest. So in other words, the recommendation is for an investment of public funds to the tune of 6% in the healthcare system, of which majority should really go to primary healthcare. So many small island economies are unable to make this level of investment in the healthcare structures to provide comprehensive services. Another big challenge is the challenge of human resources. And this is particularly an issue for the small island developing states of the Caribbean, where many nurses are trained and promptly migrate, particularly to North America. So therefore, you never have a pool which is retained for sustainable services because of the migration of human services and human resources after the investment. There's also a perception of low qualities of care. And this is one of the drivers for people investing in private healthcare rather than using the public services. So many different challenges at many different levels. And of course, with an ever evolving situation of the non-communicable diseases, which requires recurrent contact with the healthcare system for provision of services, the services are proven to be inadequate to meet the basic needs. And then came COVID. And this graphic shows the evolution of the epidemic. And I will sort of, as you well know, the region of the Americas has been at the epicenter after the initial outbreak in China, and then the movement to Europe, and now it's in the Americas. And let's go to the next slide, which gives us a bit more of a granular breakdown. So this is from the WHO dashboard of COVID-19 around the world. And as we can see, the country, the greatest number of cases and deaths is the United States of America, followed by Brazil, with over 1.1 million cases and 52,000 deaths. Also ranked in the top 10 are Peru and Chile, with more than quarter million cases in either case, as well as Mexico, which ranks at number 12. So the actual epicenter of the epidemic has moved to North America and has now moved into Latin America. So it's a tremendous challenge in the region of the Americas. What are some of the links to COVID and non-communicable diseases? With stay-at-home policies in many countries of our region, it's leading to increase in NCD risk factors such as poor diets, physical inactivity. In some cases, there is evidence of more smoking, and in fact, we're seeing also the invidious marketing of products such as nicotine has been helpful to counter COVID in some cases. And I mean, some really pernicious studies have suggested it might be a link, particularly from France. Alcohol consumption in some cases has been shown to go up in some settings. We all know about the impact of disruptions in the provision of healthcare services, with closures of many of the available services at the primary healthcare level, as well as even secondary level because of social distancing measures. Additionally, many persons have manifested a fear of attending care facilities, which has resulted in reduced elective clinic visits and lower access to services such as renal dialysis. Cancer care is also being affected adversely by this closure of facilities, as well as there are delays in high priority treatments for patients with non-communicable diseases. So in other words, we anticipate a greater risk of complications and death from diseases which are eminently treatable. And these are issues that are for which data are now becoming more available, but it's been a major crisis linked to non-communicable diseases and COVID. Next slide. At this point, I'm going to hand over to my colleague Silvana Luciani to give you a more detailed oversight of what's been happening with NCDs and COVID, and some of the data that we have found in terms of what we've done in the region in terms of surveys. So over to you, Silvana.
Thank you very much, Dr. Hennis. And just to reinforce Dr. Hennis's point, before COVID, there were many, many gaps in access and quality to healthcare in countries in our region of the Americas. And this crisis, the COVID-19 pandemic, has revealed those gaps and exacerbated the gaps for people living with NCDs. In our region, there are an estimated 200 million people with either hypertension, diabetes, obesity, cancer, chronic respiratory disease, chronic kidney disease. I'll say that there are an extraordinary amount of people that need access and continuity of care even during the pandemic. And providing services to that large quantity of people was difficult before the pandemic and has become even more so during the pandemic. And we now know that people with underlying conditions of NCDs have a higher risk of becoming more severely ill and also have a higher risk of dying from COVID-19. We see studies from the US showing that the rates of hospitalization are 6 times higher in those with NCDs, and the risk of dying 12 times higher than the regular population. And in China, there have been some studies showing that cancer patients are also at much higher risk of dying from COVID. 28% of all patients with cancer have died from COVID. And those with diabetes, again, studies showing that the risk doubles for severe cases of COVID-19. And as we know, smoking also increases the risk of respiratory diseases and NCDs. So coupled with the increased risk and the need to provide continuous care, this is a particularly vulnerable population that requires much more attention that has been given to this group during the pandemic. And so we in the Pan American Health Organization, together with our colleagues in other regions of the world through the World Health Organization, assess the impact of COVID-19 on NCD services throughout the world. And what I'm presenting here is from our region in the Americas, the disruption in services, the redirection of resources towards COVID that have taken away the necessary health resources that were previously available to serve the needs of those with NCDs. So in this graphic, you'll see that the staff, the medical staff, as well as the public health and administrative staff that were previously assigned to work on NCD programs, whether it was on risk factor prevention, whether it was on NCD management, whether it was on surveillance of NCDs and risk factors, that most people have been reassigned to the COVID response, making staff and people less available. Only one country of the 27 in our region that responded to our survey noted that there was no impact on staff reassignments during COVID. And in terms of service delivery, what we saw is that the outpatient NCD services have been dramatically reduced in terms of access. People are afraid of going to services. Providers are lacking the necessary PPEs in order to provide safe services on a continuous basis. So a lot of the outpatient clinics have been closed either partially or fully. And this has limited the access and availability for continuity of care, obviously. And so in countries where we know that patients need to go in monthly to have their quality control checks, to have prescriptions renewed. We know that there's been disruption of services, and the adaptations that are being put in place to be able to continue to serve the needs of those with NCDs have been largely around telemedicine, phone consultations, some innovations around providing services, delivering counseling and care directly in homes, delivering medicines in homes. But these innovations and adaptations with telemedicine and telepharmacy services have been very limited and restricted to capital cities or in countries that are much more well-resourced and have a much more robust health system. And so what we see is this vulnerable population of those with NCDs are even much more vulnerable now with reduction in access to services and with the limited availability of telemedicine to help fill that gap in service availability. And in addition to services, what the survey revealed also is that there are a number of activities for NCDs that have been postponed as a result of COVID, notably the population-based NCD surveys that are used to be able to monitor prevalence, and morbidity associated with NCDs. And so in all countries of our region, they've pretty much halted for fear of transmission of COVID. And so this will certainly have an impact on what data is available to be able to report back on NCD monitoring, but it also has an impact on data collection as we focus on collecting data on underlying conditions in those that have been diagnosed with COVID, those that are hospitalized with COVID, and those that die with COVID. And as we know, having that data is critical and important to planning future services, but also to planning when the vaccine is available, on how to reach these people and which proportion of the population and where the population is at higher risk of COVID and who needs to access the medicines and the vaccines for COVID-19. So we are tremendously concerned about the interruption in surveys and interruptions in data collection and surveillance systems. The other area where we've seen tremendous disruptions is in screening programs, which have pretty much halted in primary care services. And so many people before COVID were going undiagnosed in terms of diabetes and in terms of cancer. And so we fear that during the lockdown and during this disruption of services, the number of people that will continue to go undiagnosed and with uncontrolled disease will only increase, worsening outcomes for those with NCDs. And then we also see halting of technical packages that we've developed, HEARTS for hypertension control, PEN for primary essential services for NCDs, because of the disruptions in primary care level. And so what is needed as we go forward, and how is PAHO as a technical cooperation organization helping countries in our region and ministries of health? So first and foremost, we feel that the NCD prevention and management part of the COVID response needs to be amplified and strengthened. We saw that many countries in our region have considered NCDs in their national COVID response plans, but it has been limited in terms of the scope and inclusion of interventions and maintenance of essential NCD services. The issue of ensuring access and continuity of care through telemedicine or through alternative methods and alternative locations, for example, and the issue of extending the prescription durations from 1 month to 3 months, for example, and finding alternatives to get medicines to people and ensuring the supply chain efforts. All of those, we've seen disruptions in access and availability of services and medicines. And so we feel that there must be much more greater attention in terms of planning and consideration and finding the workarounds to reduce the gaps in care and access to essential medicines. And lastly, to maintain and strengthen the policies to control the risk factors. We've all seen and heard about anecdotally about the increased alcohol consumption. We've heard reports about increase in domestic violence as a result of the lockdown. Unhealthy habits have been sort of exacerbated during lockdown, where gyms have been closed, where people can't go out, and social distancing. And so this is a time to really double our efforts on promotion of healthy lifestyles and strengthening policies that promote healthy lifestyles and reduce NCD risk factors. So PAHO has been developing a series of technical guidance and tools on maintaining essential NCD services, on increasing access and supply to essential NCD medicines. And we've been working with ministries of health on providing the technical guidance documents, and also having a series of webinars with Ministry of Health officials and government officials on what some of the recommendations and guidance are. In addition, we've been helping to support policies, whether there is enforcement or kind of development of new regulations around risk factor reduction, and also reaching out to people that are affected by NCDs and living with NCDs through our communication materials, our social media efforts, and just simple messages on how to reduce risk. Hang on, I have to submit this. Very interactive, thank you. And so if we go to the next slide, there we go. Just to showcase some of our technical information that we've developed targeted to providers as well as to the public on tips to reduce risks and tips to maintain continuity of care during lockdown measures, as well as addressing mental health needs. Because as we've seen, there's a mental health pandemic alongside the COVID-19 pandemic. And we know that globally, in situations of emergency such as this, at least 1 in 5 people present with a mental health condition. And we already know that before COVID, mental health and substance use disorders accounted for over 1/3 of all disabilities in the Americas region. And so what we're seeing now with the pandemic situation and extended lockdown periods is symptoms of depression, anxiety, and substance use increasing dramatically in our region. And although we don't have robust data from all countries in our region, we have some information from Canada and the United States showing the increase in alcohol consumption, as well as the impact on stress and worry and anxiety. And so just to conclude, we want to call the need and attention to urgently address the disruptions in NCD services as well as mental health services, the dismantling of social support networks, the dismantling of the self-management supports that have been put in place in community services to help couple with the services in primary care as well as tertiary care services. This has all been sort of disrupted tremendously. And what worries us, of course, is the worsened outcomes in people living with mental health conditions and NCDs. And so NCDs and mental health need to be part of national COVID response plans, and we urgently call attention to those who have control over developing these plans or influencing what goes into these plans, and to redirecting some of the resources that are currently going on for the COVID response, to redirect some of those services to maintain essential services and essential medicines for NCDs and mental health. You know, crises like this often are moments to innovate and to strengthen gaps in services that existed before the pandemic. And so one of those is around telemedicine that has been existing for many, many years, but perhaps not implemented and utilized to its full potential. And this pandemic has revealed some of the opportunities where telemedicine and virtual consultations can be strengthened. And so we call attention to the need to improve infrastructure and methods and build up that capacity for telemedicine, as well as for surveillance system, because data collection cannot stop during the pandemic. In fact, we need more data and more data on underlying conditions and outcomes of those people who do have an NCD and are also diagnosed with COVID-19. So our attention is to call for more data collection, more robust data on underlying conditions in COVID-19. And lastly, as we work towards building back stronger and more resilient health systems, is to just keep in mind the overwhelming burden that NCDs pose on health services and systems, and the need to provide information to all providers, public health administrators on how to maintain essential services for NCDs as well as mental health. And then, you know, we've heard many, many anecdotal stories from providers of how they feel very alone in this struggle to ensure quality of care and maintenance of services for their patients with NCDs. And so to help reduce this sense of isolation and aloneness, we're also calling attention to the need to create a network, to share experiences, to participate in webinars such as this, and as well as webinars that we at PAHO put on regularly on NCDs and mental health, just to create that community of support and information. And lastly, to just stay healthy and stay well to all of you, especially those who are working in the front lines and caring for people with NCDs and COVID. So thank you very much.
Great, thank you both for that presentation. Dr. Hennis, any final words before I start with some questions?
Yes, I think the short answer is that the epidemic is going to be with us for quite some time. We are optimistic about the opportunity to have a vaccine, and the date is unclear and uncertain. It might come hopefully next year, but then again, no one knows for sure. I had a conversation with a colleague who is one of the leading professor of rheumatology in the UK, a very close friend of mine, and they're not very optimistic again because the nature of the virus, coronavirus, coronavirus, and so on, they tend to defy the opportunity, they tend to defy response to vaccines. So, you know, we're optimistic, but the short answer is we have to respond to the new reality in which we find ourselves. And therefore, the points that we're sharing with you, that we have raised, that we hope to engage a bit more with you on, will be the new reality until a vaccine might be found. So I think the whole approach to services, to NCDs, to risk factors, even to mental health, the way we look after ourselves, the way we engage, the way we think about building back better are going to be critical to how we are able to continue to journey along this pathway in this new reality.
Great, thank you. So I have a bunch of questions for you, but one thing, because I know that you both work with governments and ministry officials quite a bit, I would be really interested to know a little bit of what your experience has been. What is the pulse around governments and officials that are working to combat COVID, as you also talk to them about NCDs? What is your sense of their responsiveness to this, or even capacity to be thinking about these issues, right? For some of which we know are interrelated, but which may seem a bit sequential, right? Deal with the pandemic first and then deal with these other issues.
Right. Well, I'm going to open and I'm going to hand over to Silvana again too. But I think the short answer is that this is the first thing that we've seen this extent of an intersection between an infectious disease pandemic and non-communicable diseases. There have been data, for example, there have been links to obesity, for example, and the flu in previous epidemics. So there are links that are been known before, but the extent to which you see this interaction has been absolutely overwhelming. And as we spoke a little bit before the call, the initial response was to deal with an epidemic, an infectious disease epidemic, and their approaches. There's social distancing, there's use of PPE, et cetera, et cetera, et cetera. But as the whole idea of human-to-human transmission and the need for social distancing, and then the evolution of the fact that masks make a difference, the whole approach has changed. And then when one then recognizes that groups who have NCD risk factors or NCDs have in some cases a higher risk of having COVID, for example, those with renal disease or transplants and immunosuppressants, or those with cancers have a higher risk of having COVID. And then those who have risk factors or other NCDs have a higher risk for really poor outcomes or increased mortality. The whole approach has been gradually evolved to the fact that we recognize that we have to look at this very, very differently. And we also recognize that had there been sufficient progress in terms of tackling the NCDs, because not to emphasize that there have been United Nations high-level meetings in 2011, 2014, and 2018 about tackling NCDs. We also have the 25 by 25 WHO agenda in terms of the Global Action Plan to reduce the burden of NCDs. And had we made the kind of progress that we had hoped for by this time, perhaps the impact of the epidemic on those who have NCDs and risk factors might have been far less. So I think there's so much that we're learning, and in fact, the way that governments are now responding has evolved again with time, because we now recognize that we have to get this right. And perhaps I'm going to let Silvana give you some perspectives too from dealing frontline in her position with governments in terms of some of these approaches, because it's really has been, for many of us, an evolution in approaches and an evolution in thinking, particularly at the part of governments on the ground. So Silvana, let me let you have the word.
Yeah, thank you, Anna, for the question, because government is responsible for maintaining the health services and responding to the crisis, but it is not just government alone that can do that, right? I mean, we do definitely need that all of society response, professional associations, academic associations, civil society groups, the private sector, and we have seen a tremendous rallying of support around this pandemic and in our region as well. And I think a lot of these additional supports are going into kind of prop up the gaps and the weaknesses in the health systems that existed even before the pandemic, as well as responding to the immediate needs of, providing services for those affected by COVID. So what we're hoping for, and it's been a tremendously positive response of kind of all hands on deck, and let's build this health system response for COVID. But I think what we're hoping to do is capitalize and leverage all of those investments to then apply it to NCDs, because we know the bulk of the people who do need care are those affected by NCDs and mental health as well. Over.
Thank you. So that brings me to an important question. And Dr. Hennis, you and I have talked a lot about prioritization in global health, right? That's one of the key things we discuss in the course where you lecture. So I mean, one thing we're seeing right there, we know that NCDs are playing a major risk factor for COVID, right? We also know that we're seeing an increase of interest in discussing mental health and all of these other issues that you talked about. And then Silvana, you just talked about leveraging some of these opportunities, right? Do you think that there are ways we can really leverage what we're seeing here, this link with the pandemic, for NCDs to become more of a priority, to get increased investment like that we've never seen before, and then maintain that in a way that we didn't see with Ebola and Zika, right? Where you really had those sort of back-to-back issues, priorities, and fundings changed. What can we do?
Okay, sure. Well, I'll start. I think the reality is this: the fundamentals of what is needed really hasn't changed. The urgency has, however, changed. All the situations that we discuss in terms of intersectoral governmental approach, policy coherence, of course, governments in terms of tackling NCDs, the fact, for example, that ministries of finance may see tobacco as a way to generate income for the economy, whereas health recognizes promoting tobacco is bad for health. All these issues continue to be important. The fact that NCDs receive very little of development assistance financing, and quite often the whole investment in the NCDs tends to come back to domestic financing. These issues continue to be a challenge. But the short answer now, what can one do to tackle it? And it comes through to strengthening issues like the best buys, strengthening laws and legislation against the risk factors, building multi-sectoral coordination, as Silvana has pointed out, because the problem is so big. There's no single entity that can do it all on its own. So it's going to require a far more accelerated and coherent approach to tackling NCDs in this context. But then there have to be changes going forward. The world, as we know, has changed quite significantly. So in other words, with the burden of things like joblessness, restructuring of the way that services are provided, and I think there are things that we've seen that we never imagined. There are cities in, for example, in Latin America, where the epidemic hit so vigorously that there were bodies in the street. Health systems absolutely failed. There's a redirection of people away from primary health care to the COVID response. So a lot of the structures we thought that were robust and were going to work didn't work. So I think it's going to take a significant relook at how we do business, emphasizing the importance of investment in primary health care, bringing care to the communities where patients are. And of course, then in terms of the broad issue in terms of multi-sectoral and multilateral investments, because there's no way we can achieve this without all hands on deck. And Silvana, on that note, all hands on deck, let me hand over to you.
Sure, yeah, I just want to highlight one area that we definitely need to do more and can do more to leverage all the investments, and that's in telemedicine, right? And all of the alternative methods to deliver care, especially to vulnerable populations living in rural areas that can still, kind of benefit from that specialized care without necessarily having to travel long distances. And it's, telemedicine has been slow to penetrate in many of the countries in our region. And I think this opportunity has shown that it is possible and feasible. Now we need to scale it up and apply it more directly to NCDs and mental health services.
And I'm going to actually take a little point note that I have just following what Silvana says. Because of social distancing, it becomes very, very important. The more we look at this situation, we recognize there are many issues that are now evolving around the issue of telemedicine, the situation of infrastructure to deliver telemedicine, the access to technologies, the fact that many households don't have computers, the fact that bandwidth is not significant enough. So the more we look for solutions, the more issues that we see that have to be addressed in terms of infrastructural elements to be in place for these situations to work. Certainly at WHO and PAHO, we're delivering and developing guidance in terms of what telemedicine should look like, because one day you're in your clinic as a doctor or a health professional, next day you can't see patients. So then you need to know, how does one deliver telemedicine in this new environment? And that takes guidance, that takes expert input to provide the steps for how this will work and what it will look like. So in terms of these elements of how to develop it and what are the models to be used, how to look at issues of legislation, telecommunications, etc. This is where a lot of the work has been done by our organizations in terms of establishing the guidance and infrastructure for what infrastructure needs to look like for it to work successfully and to protect rights and to protect information. So a lot of work needs to be done for this to become a reality. It's taken place in some capital cities for sure. It's the first step, but much more needs to be done to roll this out at a level where everyone has access to it.
Great. Silvana, I'd like to get back to one of your points earlier about multi-sectoral collaboration, and we have a question from a participant asking about opportunities to collaborate with the private sector to increase financing in NCDs, and are you seeing any interest from private companies in Latin America? And you know, because you're working at PAHO, you're going to get a couple questions here about Brazil, Latin America, so we'll get there, but for now, private companies.
Yeah, so it's a great question. I think, you know, anecdotally, we've seen a lot of in-kind contributions from private sector. I'm not the best person to respond to what degree and scope of private sector engagement has taken place thus far in the COVID response in our region. But just, you know, from the information that we hear from our contacts in government and with the clinicians that we work with in clinics, it's, you know, a lot of in-kind contributions of test kits and things. PAHO is working closely with the governments in order to procure and distribute PPEs as well as test kits. And so that's one of the services that PAHO provides as part of the emergency response in the region, and working closely with governments though.
Yeah.
Dr. Hennis, I don't know if you have further information on that.
I will share at one point. I think there's been a very definite collaboration where one of the large pharmaceutical companies globally has actually determined to make a donation of insulin to many regions around the world. And that's been a really significant gift, because we talked a bit about medications, and Silvana talked about insulin, for example, and there are gaps. And therefore, one country, I don't think I need to name the company here now, has actually made a tremendous donation to all 6 regions of WHO. And this has been a tremendous example of how there can be private-public partnerships and collaboration in the interest of health. So yes, we're seeing things that have changed, but by the same token also, we have to be mindful of the genuine commitment to health. So in other words, you might see tobacco companies, for example, making face masks available and ventilators available. And this is part of a marketing strategy. So I think one has to be very guarded about sort of like where one is able to engage fully. If the agenda is really to market, but it is not in the interest of health. So in other words, if you have tobacco companies saying, we're going to give you face masks, but they continue to make tobacco products, we cannot deal with companies such as that. But whereas there's a very definite agenda in the interest of public health and people's well-being, definitely, that's sort of collaborations that we can work with and we can support.
You. So one of the areas where our participants are particularly interested in is really, I think, tangible solutions for some of these things. And so there's a question from a participant in Afghanistan who's asking, in a resource-limited setting like Afghanistan, to sustain the full package of services to all NCDs, it's just not possible. So what NCDs are at higher risk, and where should people prioritize if they have limited resources?
And Silvana seems keen to start. Silvana, you can start it out. Over to you.
Hypertension control. I would argue for hypertension control, because there's likely a quarter of the population in Afghanistan is likely to have, I don't know the data, but from our region, it's around 18% of all the people in the Americas have hypertension, and controlling hypertension can have significant reductions in cardiovascular disease deaths in a short period of time. So I would start with that as the priority. And there's a HEARTS package available on the PAHO or the WHO website that has modules and training and step-by-step guidance, a very practical tool that can be implemented by primary care providers in primary care settings to improve hypertension control.
It comes back to the point we always discuss, Anna, how to prioritize in health when everything is a priority. And I think the point Silvana makes is very important. Hypertension control reduces cardiovascular deaths, is a tremendous intervention. And also very important is tobacco, which is based on legislation and promoting and taxation and so forth. And, you know, you can save countless lives by having tobacco control measures, you know, so it's just done on the background of how, in terms of prevention, in terms of independent of how health systems necessarily work, but the impact is tremendous. And of course, you know, it's very hard to say, I will take care of this situation, but not the others. So one still has to find ways to support those who have need for diabetic medications, et cetera, but it's the recurrent problem. You have to prioritize, but you cannot withhold services and care that are urgently needed as well. And that's always a challenge. But certainly in terms of the best buys, promoting physical activity, that doesn't really cost anything for the majority of us, being physically active, promoting health, eating better. There may be, clearly for people, the choices you make will have a financial limitation, but eating better and eating healthy is also important. Tobacco limitation is critical, alcohol. So if one can look at the risk factors and promote physical activity, again, little cost, but tremendous return on that investment. But I do support what Silvana is saying, hypertension.
So I also think that's interesting, given that we had a poll up to participants and we asked them, well, and you saw it too, which health services they think are most likely to suffer. And mental health came front and center. And I would argue, I think part of that is because mental health has been a major piece of the conversation around COVID. I mean, particularly in the US, I think we've seen this a lot. Would you agree with our community of participants that it's mental health services that are most likely to suffer, particularly when you're saying we should be prioritizing hypertension issues? What do you think? Silvana?
So yeah, mental health services were weak to begin with, and the needs keep growing with the pandemic, and will continue to grow after the pandemic as well, because I think it's really tested everybody's patience with the extended lockdown, the impact on the social disruptions that have happened as a result of the lockdown, the economic impact, people losing their jobs, the difficulties in finding work, the social safety nets that don't exist in many of the countries in our region and around the world. I mean, all of this social, economic, political impact even that we've seen through the pandemic is having an impact on our mental health. And we definitely need to do a better job in providing services and supporting each other and creating those social networks and strengthening that social fabric of societies everywhere.
Yes, and I think really many more of us suffer from the mental health pandemic than will ever be affected directly by COVID. The news cycles, the insecurity, being locked down in your homes, joblessness. So we suffer far more from the indirect impact of the pandemic than many of us will have, who may never get COVID ourselves directly. And it's again revealed to us areas of providing health services that are very important, that are always there, but they've come home in a way that we never anticipated before. Quite often, the response to emergencies, because as you know, the region of the Americas is an area that has among the highest number of natural disasters annually. I mean, not going to the hurricane season in the Caribbean region in the United States, but also we were in a conference call just yesterday with people from Mexico, and there was a tremendous earthquake during the call, so they had to go offline. So, but it's always effectively been, the problem is not quite here with us directly, the problem is elsewhere. Now we're in a situation where we all are affected by the pandemic of mental health issues because of COVID. And it does reveal the gaps in the infrastructure and the weaknesses of the system. PAHO has been promoting the whole idea of mental health in primary health care, mental health in the community, trying to decentralize services, because quite a lot of the Latin American and Caribbean area, the model tends to be an asylum model with a mental health hospital. Whereas we are promoting the deinstitutionalization, but rather having mental health care within the community, close to those who need it most, and having support structures for people to be reintegrated. And I think going forward, this becomes even more important. And then, of course, access to services, which are virtual services, services through telemedicine, etc. And in fact, PAHO actually promotes this MH gap, mental health gap, which allows people who are not trained psychiatrists or psychologists, but people at the primary healthcare level, including nurses and even pharmacists, for example, and community health workers, to take basic training, to be able to diagnose and provide basic support for those with mental health problems, and then refer them on for further care. So the mental health gap has been one of our flagship programs for mental health. Also, we have the mental health and psychosocial support for emergencies. And these are areas that we've been rolling out and scaling up because of the tremendous need throughout the region of the Americas.
That's great. Thank you for describing those programs. Silvana, did you have an additional comment?
Yeah, it's sort of related to mental health, and it's around the issue of palliative care services, right? We've seen a tremendous amount of suffering, human suffering throughout the pandemic. And we know that palliative care services and access to pain relief medication, symptom control there are huge gaps in that area, and more so during the pandemic. And so I guess there's just a real need to focus a little bit more on palliative care. And I would urge people who are listening in on this to reach out to the palliative care associations in your country or the International Association of Hospice and Palliative Care that provide training and support on clinical skills around being able to build up services and provider capacities around palliative care and reduction of human suffering.
I'm so glad you brought up palliative care. It was an area, a topic that we had been wanting to explore, but I think struggling to figure out, one, who could speak to this, but also thinking about, in the US setting, this is such a resource intensive, like long-term extensive area of care, right? Something that a lot of providers in low resource settings, they just don't have the resources for that. Can you comment a little bit more on maybe strategies for thinking through how to effectively offer palliative care during this pandemic?
Yes, so there are different, as most medical disciplines, right? There's different levels of skills and competencies. And so there is some basic core palliative care skills and competencies that primary care providers can deliver. And at PAHO, we have a virtual course on the basics of palliative care for primary care providers. So I would encourage those interested in taking the course to do so. And then there's the more specialized training involving fellowships and residencies, and there are many institutions. WHO has a series of collaborating centers on palliative care that do offer more highly specialized training in palliative care. But for now, as we're in this emergency setting, if there are adaptations and services that can be provided for palliative care, we at PAHO have a network of palliative care specialists who are lending their support and skills to be able to support the community in doing that. So we would encourage people interested to reach out to us.
Great, thank you. All right, this is a broad question, but one I'm not surprised that we got. Can you comment on the current situation in Brazil? I love all the eyebrow raises. We're like, oh, Brazil.
I'm sorry, my face is too expressive. Yeah. So I think really, it really comes down to instituting the public health guidance in the interest of the community and the citizens. And I think we have learned a lot about how to manage pandemics. Social distancing is important. Many countries have gone to lockdowns to tackle the issue. Wearing masks and so forth have taken a greater preeminence over time. I think at the very beginning, no one really believed that masks made a big difference, except, for example, in healthcare situations where one has seen people with COVID. And I think we heard recently that the recommendations were limited because of a fear that medical personnel or those near people with COVID will not have access to masks. And there's a whole issue in terms of increasing the production and manufacture of masks. And we've later learned now, as more evidence has come in, that masks probably do in fact reduce the risk of spread of COVID. So that hand washing again is critical. So we have a very clear sense of what the basic rules that should be followed by communities to reduce the spread of COVID. We're also hearing about issues, for example, where there's super spreaders, and issues, for example, where choirs have met to sing, even those social distancing. There have been outbreaks where people have tried to follow the rules. And so there's a lot more that we're learning on an ongoing basis. But yes, the thing is with the evidence and information to hand, I've said all of that to lay out the context, one has to implement them successfully to make a difference. So a lot more needs to be done in some of the countries which are not doing very well. And we are seeing the epicenter of the epidemic move to Latin America. And therefore, it's really critical that the measures to decrease the spread are urgently implemented in the interest of public health. We know what to do. We now have to make sure we do it successfully.
Okay. So I want us to circle back. I think there's a great question here on prioritization, and I might end us here unless I get a few more different types of questions. But one of our participants says, you mentioned that if countries had made progress and agreed to all of these, recommendations early on, we'd be in a better place now. But you could also say that about pandemic preparedness, MNCH, neglected tropical diseases, so on and so on. So what should the roles and leadership look like now? Is this the new normal for organizations like WHO and PAHO? What about organizations like the Gates Foundation? Do you think that given this situation where people are now more aware of and familiar with some of these organizations and what they do, that people might take advice and recommendations more seriously? And what would the global working relationship at the highest levels look like now?
Yeah, it's an important question. I think the World Health Organization has played a role as leading public health institution globally. As you may know, the Pan American Health Organization was formed back in 1902. It's the oldest public health institution in the world. The WHO came out around 1948, sometime after, though we are in fact the regional office of the World Health Organization. There are other foundations such as the Gates Foundation, which also play a role based on their philanthropic outreach to improve health. And there's also the Bloomberg Initiative, Bloomberg Philanthropies, etc. And the reality is they're all working towards the same endpoint, to include health, global public health. But it takes several different players. It takes governments, not just to participate and to vet and to participate in the resolutions and the mandates, but to implement them successfully. It takes changes such that legislation is put in place and enacted and enforced. So in other words, I'm speaking more about non-communicable diseases, and we know, for example, there are lots of mandates for tobacco, but many countries take up the resolutions but don't necessarily enforce them. We speak too about the whole need for epidemic responses. We know what to do, but we need to do it. So it comes through from moving it from concepts and ideas into practice, and doing it in a sustainable way. Because one of the issues is that once the mandates are put in place, for example, with tobacco, what happens then is that there is a backlash by the companies that manufacture tobacco or sugar-sweetened beverages or alcohol. So once, because the priorities are different, many companies have responsibilities to shareholders and to investors to make a return on investment. So therefore, with the tobacco industry in particular, I'm going to use that as the example. When the legislation is in place for tobacco and they're not making money in tobacco, then they find other ways to make a profit. And this year's World No Tobacco Day spoke about the whole issue of electronic cigarettes and vaping, and trying to get a new cohort of young people to replace the 8 million or so people who die every year from use of nicotine and tobacco. So we have to recognize we cannot let our guard down at any time. So it's not just a matter of recognizing or knowing what to do. One has to do it sustainably, and not just that, one has to look for the counter maneuvers of the private sector to continue to make a profit. And the issue in terms of PP, et cetera, we know what to do. The investments have to be made. The training has to be in place. We have to get the partners on board. As Silvana said earlier on, this is multi-sectoral engagement, which has to be sustained. This has to be intersectoral engagement with policy coherence. And we have to do it every day without letting our guard down, because once we take our eye off the wheel, we lose the gains that we have made. Silvana, I don't know if you wish to comment here.
No, I want to say that before the pandemic, I think many of my friends didn't really understand public health and epidemiology and the importance of public health measures, and often saw health as clinical management and acute cases management. And so I think there's greater awareness now of what public health means, why it's important, the concept of collectively supporting each other through risk reduction, infection control. So I think there has been a shift in awareness and consciousness of public health around the world. And so this is certainly an opportunity to improve infection control and disease reduction going forward, especially as we move into the flu season in the Southern Hemisphere now.
Yeah, I think that's a great point. And I know I've heard a couple alerts come up, so I know you guys have your 10:30 meetings. But I mean, you brought this point up about, right, in the Southern Hemisphere, we're moving towards flu season, but we're also looking at countries that are considering rolling back some of their reopenings. So Dr. Salazar, one of our participants, has said that Argentina's government is considering reviewing strategies and moving back to phase 1, and it might be that other governments do the same. So now we've got this, like, we're moving into flu season in some settings. Countries are also considering rolling back. What are some of the implications for NCD management as these different things collide?
You know, just continue focusing on maintaining those essential services and finding those adaptations of what's doable and feasible in the country, in the city, in the municipality, and ensuring that everybody who has an underlying condition has the information, has the resources, and has the access to care to prevent COVID-19. And if they do have it, to have access to services for their care.
That I fully support, again, because we're in a new normal. And I think the example of Argentina is an important example. One has to adapt to a changing situation. And the fact is, if there's a country recognizes that it needs to change course, it needs to take corrective action, then it must do so in the interest of the public health. Also in terms of the NCDs, in terms of services, in terms of prevention, again, I think these issues need to be addressed proactively and urgently. The virus will be with us for some time. And if you're going to save lives, we have to do what is necessary, no matter the cause, in the interest of public health.
Well, I think that's a very nice line to end on for today. So I'd like to thank all of the participants for joining us today and giving your questions and participating. Thank you, Silvana. Thank you, Anselm, for joining us and talking about this very important topic that's very timely now, and I think it's just going to become even more of a priority moving forward. So thank you, everyone. Today is Thursday, right? Yes, it's Thursday. Thank you. So our next session will be next Tuesday, and we'll be talking about COVID and special populations. So we hope everyone will join us. Many thanks again to our presenters, and have a wonderful Thursday and forthcoming weekend. Thank you all.
Thank you for having us again, Anna. Thanks to all the participants.
Thank you, everybody. Bye. Have a great day. Bye.